This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. I'm a med-peds-trained pediatric hospitalist here at UPMC Children's Hospital, Pittsburgh, in the Policy Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since October of 2016 with these podcast episodes. Normally, we try to focus on American Board of Pediatric Content Specifications for PHM. Every so often, we'll do something special that really affects hospital medicine. And our current topic, I think, really affects all of us as pediatricians and as people. If you've been listening to the news at all, you've been hearing about immigrant families, specifically migrant children, migrant families at detention centers at the border, what's going on there. And it can be very confusing. It can be very overwhelming. So I thought we should talk about it, but I want to talk about it obviously from a pediatrician's perspective to get just that perspective because that's who we are. So with that aside, I'd like to introduce our expert guest today, who I'm very, very fortunate to have because she fits all of the criteria we've talked about. We're going to welcome Dr. Julie Linton to the podcast. Dr. Linton is an academic general pediatrician in South Carolina. Her professional work focuses on optimal care, community engagement, and advocacy for policy-level action regarding children and immigrant families with a framework on health equity. Dr. Linton is a certified medical interpreter and bilingual healthcare provider in Spanish and English. Nationally, Dr. Linton serves as the chair of the American Academy of Pediatrics Council on Immigrant, Child, and Family Health. She's co-authored several AAP policy statements, including Promoting Food Security for All Children in 2015, Detention of Immigrant Children in 2017, and Providing Care for Children in Immigrant Families in 2019. Dr. Linton is a current fellow in the Robert Wood Johnson Foundation's Culture of Health Leaders Program. So, Dr. Linton, thank you very much for joining us on the podcast today.
Thank you so much for having me.
So before we start, because this is CME associated with the podcast, we have to do our conflict of interest statement. I'm going to go first. I have nothing to disclose.
I have no relevant conflicts of interest to disclose.
I'm going to get right into it because I want to get in as much as we can on our episode today. I've read the policy statements that you were the first author for that I mentioned, and there's one for the Detention of Immigrant Children policy statement published in 2017. The first paragraph starts with a statement that just really struck me. I'm going to quote it. In accordance with internationally accepted rights of the child, immigrant and refugee children should be treated with dignity and respect and should not be exposed to conditions that may harm or traumatize them. The Department of Homeland Security facilities do not meet the basic standards for the care of children in residential settings. Being totally upfront with you, I read that and I stopped because it was to me a very powerful statement. It's a great way to start a policy statement. It's one of the more interesting policy statements, intros I've ever read. It made me want to know more about the detention centers, what's inside them, and I guess a great way to start would be, would you mind if I just asked you a few questions and you could walk our listeners through what you heard and what you saw and felt when you went to the Ursula Detention Center in November of 2016?
Yes, I'd be happy to. I was with an AAP delegation. We were doing research for this policy statement, detention of immigrant children, and we got out of the van that we traveled in to arrive there and saw a facility from the outside that had government signage, including Department of Homeland Security outside. Looked like a very large, to me, ominous building, but perhaps that's because I knew I was going into a detention facility, but was not clearly marked as such on the outside. And upon getting in, I think the most striking thing that I'll always remember is this rustling sound you can hear sort of echoing throughout. The building is a warehouse and with concrete floors, and cage-like fencing that extends from the floor to the ceiling, and the rustling sound was coming from the mylar blankets, the aluminum blankets that the children and families had around them, covering them, the same blankets that you would wear after running a marathon, for instance. And when you go into a room, a warehouse filled with children and families, as a pediatrician, the first thing I would expect would be to hear the sounds of children playing, like that would be pretty common for a huge group of people. And instead it was this eerie rustling sound and very few noises of anything cheerful. People were standing in lines waiting to meet with the consulate, and then within the cages were dozens and dozens of children and families. The unaccompanied kids or older kids had been sort of separated out into some sets of these cages, and other cages held parents with younger children. And
can you describe what you mean by cages?
Yeah, so there were chain link fences that would extend from the floor of the facility with the concrete floor all the way up towards the ceiling. And the ceiling had bright fluorescent lights, and when we asked the guards about the lights, we were informed that those lights were kept on 24/7, which as a pediatrician was pretty alarming to hear from the perspective of sleep and normalization of any form of schedule for a child who's taken a pretty harrowing journey.
Can I ask a couple more questions? When you walked in, was there, I'm assuming there was some sort of security like in the airport you had to pass through. Is that right?
Mm-hmm. Yes.
Could you hear the rustling of the mylar blankets even out there when you were going through security? Or was it too far out?
What's funny is I honestly can't remember, because my entire memory of this couple hours I spent in this facility is clouded by that rustling sound. And to the point that every time I see images of the facility, either in the news or when I give presentations about the health of children in immigrant families, I still have a physiologic reaction myself because it was so eerie. So when people talk about memories being clouded, I honestly can't remember, and I can't answer your question because that eerie crinkling sound I'm hearing in my head right now.
Okay. So when you got to where the children and the families are, you said that the families who were there with their kids were in one cage, the chain link fence from the floor to ceiling. The unaccompanied minors were in another one by themselves?
Yes, just similarly aged kids. And then we were not allowed to talk to the children in the facility, but when I see kids in the community, sometimes older kids that are in family units will tell me that they've been separated from their parent and younger siblings during processing. So I don't know whether the adolescent age children in that cage were all unaccompanied kids or whether they were kids in family units who had also been separated during processing because of their age. And they were separated, the older children, the adolescents were all separated by their reported sex as well.
Oh, so there was, I guess, separate areas.
Unaccompanied boys were in one cage-like facility, one cage-like enclosure, and unaccompanied girls were in another cage-like enclosure.
What did it smell like? When you're in that facility, was there a particular odor that hit you? Because we've read in the news that people who've gone in smelled feces once they walked in. Very, very strong. I read that in a couple of accounts. Did you have that same?
Yeah. So when I was there myself in 2016, I did not have that experience, but the reports of the odor of feces comes from the last delegation of the American Academy of Pediatrics just this summer, where the current president of the AAP, Kyle Yasuda, and the president-elect, Sally Goza, were there with Tamar Harrow, who's the director of federal advocacy for the AAP, and that was reported during their visits to 2 processing facilities during a time of high volume, and I could easily imagine that odor being true in the facility I was in. It just wasn't true that particular day.
And was there anything there for children, whether it's a few balls, books, or was it just the kids and the mylar blankets and whatever belongings it looked like they had with them?
And their belongings were actually taken from them upon entry, so they were only wearing their clothes and the mylar blanket. They didn't have any belongings with them, so any comfort objects or any objects they needed were confiscated upon arrival, reportedly to control infection. So I didn't see any toys or books in the processing facility, and the only evidence of play that I saw was there was one little boy wearing striped pajamas, probably about 4 years old, who was running through between people in one of the cage-like facilities, one of the cage-like enclosures. And it was one of the only two signs of joy that I witnessed during that entire encounter. The other was a group of unaccompanied girls who were huddled in a corner, tearing edges off their Mylar blanket and creating bows with these Mylar homemade ribbons, tying them in each other's hair. I imagine in an effort to create some level of solace and comfort amidst a really desolate situation.
How many people do you think were there?
Hundreds.
Hundreds.
Yes.
How did they wouldn't let you talk to them, but they weren't playing, so the impression I get is that they looked sad, upset. Is that right?
And frightened. They looked frightened. The people waiting in line for their consulate were holding children who were often either wide-eyed and frightened looking or sleeping after their journey, remembering that this is a facility that was receiving people 24/7, and some of the people had been there for a few hours and some of them had been there for a few days, waiting for the next phase of their journeys. And so there was a mixture of fear and sadness and anticipation in the eyes of children and their families.
Did they tell you why they wouldn't let you talk to any of them?
We asked and we were told we were not permitted to talk with people, so that was the answer given.
That was the only answer given. Okay. What other part of the facility did you go? Was that the end of the tour? Did you go to other parts of the facility, or was that the whole thing? Just a big room with separate cages for families, for boys, and then for girls?
We walked through the facility. We saw where their belongings were held. We saw a room where they reportedly were able to do basic medical observations, which, per discussing with my colleagues who were able to go this past summer back to the facility, sounded like the same room with really no medical supplies available, a few signs on the wall. I didn't see any stethoscopes or any medical equipment available or any privacy opportunities there, and there was no physician or other trained medical professional present while we were in the facility.
So you couldn't even talk to the medical staff because they weren't there?
There was no medical staff.
There was no medical staff, not a nurse, nobody?
Not present at the facility, nor, to my knowledge at that time, part of the facility. There are efforts now to change that. The House of Representatives did pass a Humanitarian Standards for Individuals in CBP Custody Act, and the corollary bill is currently in the Senate now that would require pediatric expertise at the border. There's a current requirement that all children undergo a basic medical screening, but the degree to which that is taking place and or who is doing those screenings and how that information is being transmitted is not clear.
So, Julie, can I ask, for our listeners who may not know, this border crisis or this influx of migrants, according to the policy statements, didn't start in 2016. We've had migrants coming across the border in larger numbers since, when I remember reading, 2013 or so. Is that correct?
That's when the increase began, but there have been migrants coming across the border for a number of reasons for decades. And there have been a number of protections in the setting of that have come through our legislature in an effort to provide protections for children and families that unfortunately have been undermined by the current administration. The Flores settlement from 1997 was a protection that would ensure that children would be held in the least restrictive setting possible, and that ideally would be held in facilities that were licensed by child welfare agencies. And then in 2008, the Trafficking Victims Protection Reauthorization Act was passed that would require that Customs and Border Protection screen children from Mexico and Canada for trafficking, both child labor trafficking and sex trafficking and other harms, before allowing them to return to their home country, in an effort to ensure that children from Mexico and Canada, called contiguous countries, would be afforded the same protections as children from non-contiguous countries. And unfortunately, there have been a number of efforts to undermine these protections, or worse, to refer to these protections as loopholes, whereas these protections have actually been in place for the TVPRA more than a decade, and for the Flores settlement agreement more than 3 decades in an effort to protect children who, by and large, are fleeing countries of origin for a number of reasons and seeking safety. And these protections are designed to be consistent with international law and to be consistent with what myself as a pediatrician would view as very basic protections to keep kids safe.
So then prior to 2016, we were having this increase in migrants. How were we processing them and where were they going before we started using these detention centers to the level that we are?
So this policy statement is reflective of all of the detention conditions that have taken place since that increase. So it's not specific to administrations. I think what's different now is the efforts to undermine any forms of protection that are critically important, such as the Flores Settlement and the Trafficking Victims Protection Reauthorization Act. And what's also different is some of the systematic cruelty that we've seen under the current administration, such as systematic separation of children from their families, as well as efforts to vastly increase family detention that we've been seeing in conversations and potentially in implementation over the past couple of years.
I guess what I'm trying to ask, and I don't know if I'm asking correctly, is were we doing something differently prior to putting these kids, definitely prior to family separation, but prior to putting everyone in these large detention centers, was there a policy in place where people would be processed for seeking asylum and then be released to the Catholic Charities or a family member or something while their paperwork was being processed? And did we switch that? Does that make sense?
So that's a difficult question. I don't think there's ever been a clear process for that. That still does occur, but rarely. So the typical process, and for the details, the Detention of Immigrant Children policy statement outlines that. But what we would argue for as pediatricians is that as soon as possible, every child be released into the community and with their parents, or released to a sponsor if they're not traveling with a parent in the case of unaccompanied kids, as soon as possible. And I think the current administration is much more heavily arguing for and trying to advocate for prolonged detention of all children and families or all people for as long as possible until their cases are heard throughout the duration of their case, which is not only inhumane and dangerous for their health, but also incredibly expensive. And so it's not that there is a change in the fact that detention exists, because family detention centers have existed for a significant period of time. Currently, there are only 3 family detention centers, the Dilley facility in Texas, the Carnes facility in Texas, and the Burke facility in Pennsylvania. But what's different is the efforts to vastly expand detention as cases proceed, rather than allowing people to be in the community, learning, seeking health care, and remaining safe until they can go to their court case.
And these family detention centers they would like to expand, or it's exactly what you saw in Ursula in 2016, these facilities with the Mylar blankets, the lights always on, and people sitting around. Is that right?
There's sort of step 2 of that. The process diverges at the processing center. So a processing center is sort of the first step. Once somebody is apprehended or presents himself or herself to Border Patrol, there's a diversion at that point. If it is a child in a family unit, they will ultimately be under the custody of Immigration and Customs Enforcement, which is under the Department of Homeland Security. That would either be released into a community setting by essentially getting told, go find a bus and get to your community. Thankfully, the border communities have created incredible resources to facilitate that movement, people to get to where they need to go. Or are they going to a detention center, Dilley, Carnes, or Burke, or one of these new places that people are trying to construct? If it's an unaccompanied child, they go under the custody of Office of Refugee Resettlement, and they are sent to a shelter until there can be a sponsor identified, in which case they're released into the community.
Can we focus on the unaccompanied children and the ones in the shelters? How
Absolutely.
many do you think there are currently in the U.S., unaccompanied children migrants cross the border who are in these shelters? Do we have any idea?
Yes, that data is actually possible to pull, and the data is publicly available under the Department of Health and Human Services under the Office for the Administration of Children and Families. The data on unaccompanied children is actually publicly available and reported on a monthly basis. So in fiscal year 2018, there were 14,088 unaccompanied children who were served by post-release services, meaning they actually received additional services in the community, and there were 49,100 referrals that Office of Refugee Resettlement got that were placed with sponsors in the community. And that data for each state and even each county, for any county that receives more than 50 unaccompanied children, can actually be accessed very easily on their website. And so when in my own community, I am always aware of how many unaccompanied children are coming to my community on an annual basis, so I have a sense of what numbers we're getting and how we can support kids and what kind of resources we're going to need to meet those needs, and that number is available across the country.
Now, just so I understand, the Ursula Detention Center you went to, is that a processing center where then the kids diverge, like we talked about? And when you were there, I guess what I wanted to know, did you get a sense of when they ate, how they ate, were there tables, or did everyone just get food and sit on the floor? How did that work?
So what we were told at that time, and also what's been reinforced by kids that I see in the community who describe the conditions to me as well, is typically they're given food 2 to 3 times a day, oftentimes not enough that kids will report, and oftentimes access to water or appropriate fluids. For example, a child who may be dehydrated, there's not readily accessible Pedialyte or Gatorade available for hydration. But the food, I've had anything described to me as sandwiches with some deli meat, a couple slices of deli meat on bread, or burritos, and I've had children describe to me that the sandwiches were kept so cold the sandwich was actually frozen. 2 children describing the food as sufficient for them, that they were okay with it. They are not served meals at tables. They're served the food, from what children have told me and what we heard at that time, within the enclosures that they're kept in.
So can I ask another question about the facility? You were there in Texas in August, which is very hot. What was the temperature like in the facility when you walked in? Was it air conditioned well? Was it too cold? How was it?
So when I was there, it was cool, probably on the cool side of room temperature. And I've heard those temperatures described to me, included by physicians, as being cold or frigid at times that they've been there. And kids will often describe the temperatures as extremely cold. But that's not surprising to me, given that somebody is going from having to travel in extreme heat for 3 months plus, perhaps, to being held in a highly air-conditioned warehouse, would be incredibly cold, oftentimes wearing very little clothes and given only a Mylar blanket, may be frigid for a child. And I've heard physicians who have been in these facilities describe them at times as extremely cold. The day that I was there, it was on the chilly side of air conditioning.
And so these kids are getting to the detention centers, processing centers. Their belongings are taken and stored. They're given a Mylar blanket and the clothes they're wearing. They're put in this gigantic room, from what you're describing, divided up by these fences, almost chain-link fences, from floor to ceiling. Families in one section, boys of a certain age in another, girls of a certain age in another, with there's nothing childlike there like we would have at a children's hospital. There's not books and toys and a child life specialist there. They're given 2 to 3 meals, what sounds like in brown bags, to eat there a day. There's not snacks and drinks if someone's dehydrated or well, I didn't ask this. What if the kids get sick? There's that little room, and you said that there isn't any medical staff of any that you know of or that you met there. Do you know if they send the kids to a local hospital to get evaluated? What if they're ill?
So our understanding, and what I've heard from Border Protection as well as from children, is that if a child's seriously ill and a request is made to see a medical professional, that access is intermittently available, depending on the assessment made by that particular agent. So there are certainly many children who are referred out of a facility with concerns for their medical condition, and they may be evaluated in a local emergency room or urgent care facility, and that determination is made whether they're sick enough to require admission or whether they should be returned to the processing center. So myself and pediatricians across the country have taken care of children who have received referrals to emergency rooms or even inpatient facilities near the processing centers, and only to be returned to the processing center to recover from their illness. So one of the recommendations in the Humanitarian Standards for Individuals in CBP Custody Act, as well as recommendations in the American Academy of Pediatrics, is that if a child requires emergency care or certainly hospitalization, that they should not be returned to a processing center, but they should be moved to the next phase of their journey to be allowed to recover, because the conditions that you've just described back to me and that I saw and I've had children tell me are certainly not safe for recovery from an illness. Additionally, the conditions are not safe for prevention of illness. So one of the things we haven't yet talked about in the processing centers is that the toilets are essentially porta potty-like toilets that are not fully enclosed, and the sanitation is limited. So there are hand washing stations at some of the facilities. The one that I saw had hand sanitizer available, and so certainly not conducive to prevent the spread of illness, including things like diarrheal disease. And so although there's no evidence that a child is coming in with illnesses, in fact, a very large study from the Lancet showed that immigrants are actually perhaps likelier to be healthy upon arrival to their country of origin. The conditions that we're seeing in these processing facilities are conducive to the spread of infections such as respiratory illness like the flu, which we've had children die from over the past several months, and diarrheal disease. And there have been cases of highly infectious diarrhea that have been obtained or contracted in these processing centers, including Shigella.
Do you have any idea how long these kids stay in these processing centers, or how long they are staying in the processing centers?
So they're not supposed to be staying in these processing centers more than 72 hours, but there have been children, to our knowledge, for several days held in these facilities. The longest I've had a child tell me they've been kept there was around 7 to 8 days. Sometimes families aren't even able to tell me how many days they were in the facility because it's so confusing because of the lights being kept on 24/7. But they're not supposed to be held there more than 72 hours.
Wow. Do you have an idea, roughly looking at the kids, you weren't allowed to talk to them, but what age ranges were in the cages together? Was it like 5 to 16-year-olds for the boys, or what did you see?
The ages that I saw separated off on that particular day were probably 10 or 11 and up, and that's consistent with what kids have told me in the past, that when the older kids that I've taken care of that have been traveling with a family, a parent, and or siblings have been separated if they were pre-adolescent or adolescent age and above. But these assessments of age are made by the child's report and or the arbitrary determination by a border agent, as a child may or may not have documents with them upon arrival. Typically children, are coming with some type of identification, but whether or not those are believed in terms of age can vary. In the news, there was a lot of coverage for the families being separated at the border and staying separated for months at a time. Mm-hmm. I guess the first question I have is, do you know that policy, are we still doing that? Yes. So systematic separation of all kids from parents is no longer the case, but there are still ongoing separations that are not for clear cause. So the American Academy of Pediatrics advocates that no child should be separated from a parent unless the safety of that child is at risk at the hand of that parent and a competent family court makes that decision. And a simpler way to think about that is that we would advocate that no child be separated from a parent unless it's clearly in the best interest of that child. And there are ongoing separations reported by legal advocates and partners of the American Academy of Pediatrics, such as the Kids in Need of Defense, or KIND, as well as the Young Center for Immigrant Children's Rights, that continue to report separations of children from parents or caregivers for no clear cause and no clear indication that it's in the best interest of that child. And personally, having cared for some kids who have been separated from a parent without clear cause, it's incredibly destructive to their physical, mental health, and to their general well-being.
So am I correct in assuming KIND, the two firms, like the two charities you brought up, are they legal resources that these kids are seeking out, or how do they know about it, that these kids are being separated from the parents still? I guess is my question.
Both KIND is Kids in Need of Defense and the Young Center for Immigrant Children's Rights both offer, as part of the work that they do, legal representation for unaccompanied children and or children who've been separated from parents or guardians as part of the work they do. And so they will report in their advocacy work on some of these cases. Jennifer Podkol, who's one of the attorneys with KIND, Kids in Need of Defense, and Jennifer Nagda, who is one of the attorneys and the policy analyst for the Young Center for Immigrant Children's Rights, have both also testified for Congress regarding previous and ongoing separations of children from their parents.
These kids are going to these shelters when they're separated from their parents after they go through the processing centers. Then am I correct in saying that they're going to these shelters waiting for a sponsor of some type? Is that right?
Yeah, so when a child is separated from a parent or guardian, they're subsequently processed as an unaccompanied child, even though they didn't come to the border unaccompanied, and they then go under the custody of the Office of Refugee Resettlement.
Okay. And where do they reside then?
The shelters from the Office of Refugee Resettlement Unaccompanied Children's Program are shelters all across the country. And then the Office of Refugee Resettlement Unaccompanied Children's Program has the task of identifying sponsors, typically relatives of children who are able to identify that person through a number of ways. And then once that sponsor has been cleared to be safe for the child to be released to, that child can be released to that sponsor.
And am I correct in assuming these kids are coming from countries all over Central America and maybe South America, and they have different levels of reading and writing ability? So then the ability of us to reunite this child with his or her family is challenging because we still have some children we haven't reunited. Am I right in all that?
So the children that come to our border are from all over the world, in fact. The Sentinel family separation case, the Ms. L case, which was brought to light through the ACLU, was actually a mother and a daughter from the Democratic Republic of the Congo in Africa, who had been separated at the border for several months. And so it's not only countries in Central America, but actually all over the world, particularly in light of the administration drastically reducing refugee resettlement. We're increasingly seeing children from a diversity of countries speaking a diversity of languages. The most common countries that we're seeing in the setting of our southern border are the Northern Triangle countries, which are El Salvador, Guatemala, and Honduras, as well as children from Mexico. And not all of these children speak Spanish. Some may speak indigenous languages, particularly those from Guatemala. And to your point, the educational levels and the literacy levels vary tremendously based on not only the age of the child, but the educational opportunities that child had. I'll share, I've had children that I've taken care of who were unable to go to school because they were told by a gang member that if they didn't join the gang and they tried to go to school, they would be killed. So they were hiding in their home until they fled for safety in the United States. We're not talking about children who are not deeply wanting to go to school. The kids that I take care of are so excited to go to school and do the work of childhood, which is to learn and to grow something that's been denied to them that they're only hoping to be able to do.
Wow. I did not know. I was not aware that we were getting children from all over the world, from Democratic Republic of Congo and other places, I guess, flying in and then trying to cross the border to get into America, which I think would complicate the problem for everyone with a huge diversity of languages. It's literally from all over the world. Wow. I guess that since this is a podcast for a hospitalist, as you can tell, I am not someone like you. I haven't got a master's in public health. I'm a hospitalist. I'm a pediatrician. So I was very interested in this podcast. But what can I expect as a hospitalist? Should I expect to see more patients who are migrants who are coming up to even Pittsburgh to be admitted for illness or this or that?
So that's such a great question. To clarify, I actually don't have a master's in public health. I've actually learned most of the policy regarding children and immigrant families from my legal colleagues as well as my advocacy and child welfare colleagues. But to your point, I think what I hear from hospitalists and even critical care doctors across the country is that they're having children show up in their hospitals who have been released from processing centers very sick. And I've received an email from an intensivist in a state in the Northeast who had a child with respiratory failure who had been released from a processing center with respiratory illness. I've had children with severe dehydration that I've heard stories about from pediatric colleagues across the country who had diarrheal disease, were released from a processing center and subsequently upon arrival to their community admitted urgently to a hospice service for rehydration and treatment. So I think as a hospitalist, I would anticipate that you may see children with chronic illness whose medications have been confiscated and not been returned by border agents, things like seizure disorders or rheumatologic conditions or even oncologic conditions who require urgent management of those chronic conditions, or children who are either typical kids or kids with chronic illness who've gotten an acute illness, such as a respiratory illness or diarrheal disease, that was acquired during their processing, who was released without treatment or may have received treatment and be returned to a processing center, who may require urgent care. And I think that really adds a number of opportunities to do while you have a child in the hospital. The first is to recognize that if this is a newly arrived immigrant child, they may have a number of urgent needs beyond their urgent medical needs. The three categories of urgent needs, once a child is medically stabilized, which is the core job of the hospitalist, is to ensure that that child has access to medical care in the community once they're discharged from the hospital. And in some communities, there may be more or less access depending on which state you live in and what's available in your community. There are 6 states plus the District of Columbia that offer medical coverage to all children regardless of their immigration status. So those are California, Oregon, Washington State, Illinois, Massachusetts, New York, and the District of Columbia. And if you happen to live in one of those states, you will have more access to medical homes upon discharge from the hospital than those of us in the rest of the country. For the rest of us, those options may include federally qualified health centers. They may include public health facilities like departments of public health that may offer medical homes through family physicians or pediatricians. That may include free clinics, or that may include some type of community-sponsored charity care programs. I would hope that for children with medical complexity or chronic illnesses, such as children with Down syndrome or children who have some type of underlying medical problem, that there would be an opportunity for hospitalists to develop relationships with medical homes that would be able to provide either charity care or covered care for kids who may not be eligible for health insurance. The other urgent health need for many children who are arriving is mental health. Secondly, educational needs. So every child, regardless of their immigration status, in every state in the United States is eligible for free public education through age 21 or even a little bit older if they have serious disability. And I think that's really important because children may or may not even know that they're eligible to go to school. And that's a critical opportunity for kids to begin to learn about systems in the United States, to learn English, to make it easier to be employed as their immigration cases proceed. And then finally, and perhaps most importantly, is legal representation. So as pediatricians, we are uniquely equipped to get a history from a kid. And we may uncover really important information in our history taking that may actually confer eligibility for legal relief for a child that may not otherwise have been obvious. So a child may disclose that a parent or guardian has abused, abandoned, neglected them, which may mean that they're eligible for a particular status called special immigrant juvenile status. A child may disclose that they've fled their country of origin because of fear of return to that because of membership in a particular group, such as being an ethnic minority, indigenous community, or identifying as LGBTQ. And those may be particular categories that may actually be grounds for asylum for some children. And so these kind of information is really important because developing relationships with legal representation, lawyers, or letting social workers know that that child needs an immigration attorney can be really important to ensuring that kids have a chance to have their case heard and that they have an opportunity to have access to the type of protections that they merit based on what they've experienced or suffered in their lives.
So if I understand this correctly, I want to repeat this back to make sure I get this, and those of us who are home who can make sure we understand this. If we are doing a history and physical on a child who's coming to us to the hospital because of an acute illness, and we find out that they're either being abused or neglected by a parent or caregiver, and or they're a member of an ethnic group or otherwise that is, I guess, causing them to be in danger in some way, whether that's LGBTQ or an ethnic minority or something in their home country, we'll know now that we can, for us at Children's, I would probably talk to our social worker, let them know this, and make sure they get an immigration attorney for the child to help them. Did I get that right?
Yes, and I think the take home is that every child that has recently arrived who has an immigration hearing coming needs an immigration attorney. But we as pediatricians may uncover particular details in their history that are really important to be able to share with an immigration attorney. So what I typically do is I get a signed release if I don't have a parent or guardian available, but typically you'll be seeing kids who are either with a parent or guardian or have been released to a sponsor. And you can get a signed release to disclose the information to an immigration attorney if the child or family is interested in that, and by and large, kids are very eager to have legal representation because no child should ever have to represent himself or herself in court. The information that we as pediatricians uncover, can oftentimes be very supportive of their case, and there's very good evidence that when physicians and attorneys are able to work together on cases, the likelihood that the case will be successful is much greater, and there's an entire field of asylum medicine that looks at this. But for children, there's a few additional options in addition to asylum that are important to be aware of, such as special immigrant juvenile status. And then furthermore, if the child's been a victim of crime in the United States, they may be eligible for a crime victim visa. Or if the child was trafficked here either for labor or for sex, they may be eligible for a different type of visa called a trafficking victim visa. So I think the take home for hospitalists is the histories that you uncover in the hospital may actually be relevant not only to their medical history but to their legal case. And so ensuring that we're able to refer children to immigration attorneys as part of their medical care, as part of their social needs, is a really important consideration for children who are recently arrived here in the United States.
Now, you said if the child's unaccompanied and they're in the care of a sponsor, we need to get a disclosure, but we would get the sponsor to sign a disclosure, or how would we be legally, I guess, allowed to just call the child's immigration lawyer and say, I got this information for you?
The sponsors essentially have temporary custody of children. If there's a major surgical need or something like that, Office of Refugee Resettlement will be able to speak to what is or is not allowed based on the sponsorship determined. And,
going back, I want to make sure I understand this right. These children are when they come across the border seeking asylum for various reasons, they end up in these detention centers, which are processing centers, and they're not supposed to be there for more than 72 hours, but from the children you have spoken to, they've been there, a lot have been there longer, and we've talked about what's there. I guess what's most upsetting is what you brought up, which is if you have a child coming over with a chronic medical illness, whether it's asthma or they have Down syndrome and have some cardiac issues associated to that, or, they have a seizure disorder, their medicines are taken away. And even if they go into an acute facility because they have a seizure or they have an asthma attack or they have something, when they get discharged, they go back to the detention center. And if they're given medicine from the hospital, you need to take albuterol every 4 hours for the next 48 hours and here's steroids. I don't know what happens to that medicine when they get back to the detention center, but I'm assuming it's taken away. Am I wrong?
The medicines that are taken away are those that are not prescribed by a U.S. licensed provider. And so typically if a child with medical complexity is coming across the border with medicines from their home country, it's not a U.S. licensed provider. My understanding is if they come back to the facility with a medication that has been prescribed from a hospital, that that medication would be allowed in the facility. The question that I have is if it's an unaccompanied child, I don't know who's administering that medication depending on that child's ability to provide his or her own care. And so I think there's a lot of questions that remain regarding the adherence to those medications depending on what is available or not available. But certainly one of the most common things we'll hear about is children who have sought emergency care who are returning from the emergency room to a processing center with Tamiflu. And that medication is reportedly available to them if they have been prescribed it by a U.S. provider in the processing center. But I've taken care of children who've been prescribed medications such as amoxicillin at an urgent care that the family never got, but they do get the Tamiflu.
And
so I think it's pretty inconsistent and difficult.
I've been seeing on NBC News and other regular lay sites, what's been reported is that the detention centers will not be giving flu shots to children. Is that what you're hearing as well?
Customs and Border Protection does not routinely administer influenza vaccines. The only administration of influenza vaccines for immigrant children that I'm aware of is all routine vaccines that are administered when children are in the custody of ORR for unaccompanied kids. Certainly, the AAP would recommend that all children 6 months and older receive the flu vaccine and all routine vaccinations on schedule. And so this is one more example of children not getting the care they need when they're in CBP custody, and one more reason why the Academy urges our federal government to rapidly increase pediatric expertise at the border.
So, we're wrapping up our time. I'm going to ask you one more question, and I always give our expert guests an opportunity to say anything that we did not mention that you would have liked to talk about, and I apologize for that. I guess my last question is, for those of us who are pediatricians or hospitalists or whatever, who don't like the idea of children being separated from their families and detained in these cages for extended periods of time, and we would like to do something to help prevent it. What should we do, whether we're AAP members or not? How can we help?
Certainly, I think contacting your elected officials, particularly in the Senate side, because in that Senate Bill 2135, which is the Humanitarian Standards for Individuals in Custody and Border Protection Custody Act, is currently active, and the House component of that has passed, and the American Academy of Pediatrics has endorsed that. So supporting the Humanitarian Standards for Individuals in Customs and Border Protection Custody Act is one step that anyone can take regardless of whether they're an AAP member or not. I certainly encourage pediatricians to join the AAP because the AAP has been active in speaking up against medical and other broader health concerns for immigrant children, perhaps more so than any other health organization. And for those that are particularly interested in this, I'd encourage you to consider joining our new Council on Immigrant Child and Family Health, which was just established in July of 2019. We were formerly the Immigrant Health Special Interest Group. And so I'd encourage people to join that. And also for those interested in legislative advocacy, I'd encourage people to become a key contact for federal advocacy for the American Academy of Pediatrics, which will keep people informed of immigrant health-related issues as well as a breadth of advocacy opportunities. And I think that, to close, I would just encourage my hospitalist colleagues to feel empowered that you are actually seeing the sickest kids who are coming in to the United States with oftentimes underdiagnosed or undiagnosed medical conditions or serious medical conditions that require greater care. And there's an opportunity to partner with colleagues who have a special interest in the health of immigrant children, as well as our colleagues in the legal profession, to ensure that kids have a chance to get access to care that they deserve, as well as a chance for their case to be heard.
Well, Julie, I think that's a great way to end. I can't tell you how much I appreciate your time. Did we hit all the topics we should have hit today?
I think we did. Thank you so much for covering this. I think one of the things that we're hoping to have with our new council is really to expand our work regarding children and immigrant families to all pediatric specialties within the AAP, because all of us in pediatrics, regardless of whether we're community pediatricians or hospitalists or subspecialists, have the opportunity to care for children and immigrant families, including recently arrived immigrant children. And I think there's a lot of opportunity to partner with the new council and to really create some interesting movement between some of the silos that unfortunately do happen in our field. So thank you for having me.
It was my pleasure. I think I can speak for all of us when I say, the pediatricians as well, may disagree politically, which is fine, but I think we all agree that we care about kids and we want every kid that comes that we can help to be treated humanely. So thank you for your work. Thank you for being on today. I really appreciate your time.
Thanks for having me. I really appreciate you as well. Thanks, Tony.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.